Today's webinar is entitled Improving Diagnostic Quality and Safety. The Time is Now. My name is Becky Jones, and I'm the Director of Data Science and Research at the Patient Safety Authority, as well as the Director of our Center of Excellence for Improving Diagnosis, and I'll be your moderator for this webinar. After the webinar today, you'll have a better understanding of the scope and impact of diagnostic error and why the time is now to begin working on the significant patient safety issue. You'll also develop a broader understanding of diagnosis as a process that involves an entire team of people, including the patient and family. Finally, you'll be able to recognize areas of high priority and opportunity so you can start focusing your improvement efforts. Before I introduce our main speakers for this webinar, I'd like to provide a brief overview of our Center of Excellence for Improving Diagnosis. Back in 2016, our board at the Patient Safety Authority identified diagnostic quality and safety as a priority area of focus. As we started doing more work in this area, we realized a need for devoted resources and expertise, which led to the creation of our Center of Excellence in June of 2018. Pictured here is our core team from the Center of Excellence. On the top row, you have me on the left, and then our two speakers for the webinar today, Dr. Timothy Mosher and Catherine Reynolds. On the second row, you see three of our senior patient safety liaisons, Susan Wallace, Bob Yanish, and Jeff Bomboy, and Matt Taylor, one of our patient safety analysts. As you can see here on the slide, the vision for our Center of Excellence is that accurate and timely diagnoses are communicated to all patients. And our key objectives are knowledge, connection, and action. Our work is focused on gathering, synthesizing, and sharing new and existing information to broaden awareness and understanding of this issue. We also are building partnerships and creating new networks to accelerate and scale our improvement efforts. And for example, the Patient Safety Authority is a member of the Coalition to Improve Diagnosis, which is a collaboration of more than 50 diverse healthcare organizations, all focused on improving diagnostic quality and safety. Ultimately, to make improvements, we all need to act. And at the end of our webinar today, I'll tell you a little more about a project we have underway in our Center of Excellence that will help Pennsylvania hospitals identify areas ripe for action. Now I'd like to introduce our speakers for the webinar. First, we have Dr. Timothy Mosher. Dr. Mosher serves as Physician Advisor for the Patient Safety Authority Center of Excellence for Improving Diagnosis. He's also the Kenneth L. Miller Chair of Radiology at Penn State College of Medicine and a Distinguished Professor of Radiology and Orthopedic Surgery. Dr. Mosher is active in the field of diagnostic error in medicine, serving as a member of the Board of Directors for the Society to Improve Diagnosis in Medicine and as a representative of Penn State Health in the Coalition to Improve Diagnosis. Our second speaker is Catherine Reynolds. Kathy is a patient safety liaison for the Patient Safety Authority and one of the core team leads in our Center of Excellence. In her role as a patient safety liaison, she works directly with more than 80 healthcare facilities in Pennsylvania and surrounding areas to improve patient safety through consulting, education, and collaboration. She also co-led the HAP-HIN Diagnostic Error Project and has presented to a variety of audiences on the topic of diagnostic quality and safety. Dr. Mosher, I will now turn the program over to you.
Thank you, Becky. It's a pleasure to join you today. And just a few disclosures before I get started. I just acknowledge I'm a paid advisor to the Patient Safety Authority Center of Excellence for Improving Diagnosis that Becky just described. I'm also an unpaid representative to the Coalition to Improve Diagnosis, representing Penn State Health, and an unpaid member of the Board of Directors for the Society to Improve Diagnosis in Medicine. I think we need to remember behind every diagnostic error, there's a patient. And so I'd like to start with a clinical scenario that probably many of you have experienced in your own practice. This was a 34-year-old man who presented to the emergency room with acute onset of left flank pain and hematuria with suspected diagnosis of renal colic. He underwent a non-contrast CT examination, the images are shown on the slide there, which demonstrated 2 renal calculi in the distal left ureter and moderate hydronephrosis. The radiologist made this detection and determination on his report, but also mentioned in the body of the report that there were several slightly enlarged lymph nodes in the left upper quadrant, and they were of uncertain diagnostic significance. Fortunately for the patient, about 18 months later, he presented with a large conglomerate mass of lymph nodes within the abdominal cavity and had a diagnosis of non-Hodgkin's lymphoma. This demonstrates some of the challenges we face in diagnosis. Obviously, there was a anchoring bias here with that clinical history. Everyone on the diagnostic team was thinking about renal colic, and there was an opportunity to make an early diagnosis of an alternative problem related to the non-Hodgkin's lymphoma that was described later. It also represents some of the system issues, the communication. Although the diagnosis and identification was made in the report, it wasn't communicated back to the clinical team, and there was no system process in place to follow up on this finding. Now, the diagnostic error is one of the large umbrella of medical errors. The history of medical error is longstanding, but really came into prominence with the 1999 IOM report to Error Human and the subsequent publication in 2001 on crossing the quality chasm. In that report, it was estimated that between 44,000 and 98,000 patients die in hospitals each year as a result of medical errors that could have been prevented. A lot of those errors focused on medication errors, wrong site surgery, hospital-acquired infections. But one of the largest contributors to error identified in that report was diagnostic error. Subsequent to that report, there were studies that came out of the Lucian Leap Academy that approximately 40,000 to 80,000 hospital deaths annually result from diagnostic errors. And this was based on extrapolation of autopsy data that indicated approximately 10 to 20% of hospital deaths were related to an undiagnosed condition. More recently, a report by David Newman-Toker and colleagues really, I think, shed a light on the impact of diagnostic error. It was recognized in a review of malpractice cases that diagnostic errors were the most common cause of medical error related to significant patient harm. In their report, about 1/3 of medical malpractice claims were related to diagnostic errors. They're also recognized to be one of the most catastrophic of medical errors. Similar to the case that we had before, delayed diagnosis in serious conditions such as cancer can lead to significant patient impact and patient harm. Autopsy data indicates that 10 to 50% of the hospital deaths are related to misdiagnosis. So these errors can lead to patient death and long-term patient disability. They're also the most costly of medical errors. Based on estimates of diagnostic testing and additional medical care required to account for diagnostic error, it's estimated that between $100 billion and $250 billion of annual healthcare expenses are related to diagnostic error. So I think that's important to keep in mind. These are common, they're catastrophic, and they're costly. As a result of the impact of diagnostic error as a source of medical errors, in 2015, the National Academy of Medicine report issued a document improving diagnosis in healthcare. Now, although they didn't put forth the large number, similar to 40,000, 80,000 that was seen in the original IOM report, they made the following statement, that diagnosis, and in particular the occurrence of diagnostic error, has been largely unappreciated in efforts to improve the quality and safety of healthcare. The result of this inattention is significant, and the committee concluded that most people will experience at least one diagnostic error in their lifetime, sometimes with devastating consequences. And many of you listening may have had your own personal relationship with diagnostic error or a family one. It might be able to relate to this statement. There are some things about diagnostic errors I think that make them particularly challenging. It was recognized in that decade after the initial IOM report that although diagnostic errors were a significant cause of error, they didn't really receive a lot of attention, and there wasn't a lot of focus on what can we do to solve the problem of diagnostic error. Bob Wachter in 2008 wrote a very interesting editorial in Health Affairs that focused on some of these reasons. One was that the heavy focus of the IOM report was on process errors related to system-based solutions that diverted the attention and resources from diagnostic error. We'll talk a little bit about some of the drivers of diagnostic error. One of the other challenges is that diagnostic errors are difficult to define and measure. Also, most of diagnosis occurs in the outpatient setting, and that has a fragmented delivery system, and it's much more difficult to implement widespread solutions in that setting. As we'll discuss a little further, diagnostic errors are multifactorial and related to both system and cognitive causes. Also, there's a long interval between when diagnostic errors occur and when the patient has an adverse outcome. This is quite different from wrong site surgery or medication errors, which those errors can be identified rather quickly. And finally, there's not a strong business model for reducing diagnostic error. These are primarily provider-driven, and they lack a lot of the resources necessary to make systemic improvements, and they don't have some of the accountable entities like the Joint Commission and other things that hospital-based services have to deal with to drive change. Now, one of the contributions of the NAM report was they developed a working definition of diagnostic error, and it really is patient-centered and focuses on two aspects. The committee defined diagnostic error as the failure to establish an accurate and timely explanation of the patient's problem, or a failure to communicate that explanation to the patient. So it's not enough just to make the diagnosis. It also has to be communicated back to that patient. And I think that's an important thing when we think about the systems approach to addressing diagnostic error. And that's important. We oftentimes think about diagnosis as an individual patient-provider relationship, something that occurs in the office. But I think we have to expand our perspective of what causes diagnostic errors to make sure we're including the entire health system. The NAM report included this conceptual model of the diagnostic process and really divided that process into three phases. I like to think of the first phase as the pre-analytic phase, that period of engagement that really has to deal with the patient. The diagnostic process really begins when the patient first experiences a health problem. So part of the things that can contribute to diagnostic error is failure to recognize the fact that the patient's having a problem. We can see these in certain conditions, such as stroke, that may be unrecognized by the patient. So there, a public awareness campaign is one of the things that's going to be important to reducing the impact of diagnostic error. The second step is the patient has to engage the health system. And not all health systems have appropriate resources necessary to deal with those patients, particularly in some of the more rural areas within our state. Advanced resources, such as the ability to do perfusion-based CT imaging, may not be available. It may lead to a delayed diagnosis of a stroke. I'm going to jump to the later phase, the post-analytic phase, which is really dealing with more of those systemic issues to make sure that we're closing the loop on diagnostic processes. These are IT solutions related to getting the diagnostic report out to the appropriate provider, having access to appropriate clinical specialists for referral, and getting the patient engaged in that process so that they're aware of the diagnosis that they have. A lot of these deal with IT solutions and systematic issues. The recent Act 112 that was passed in Pennsylvania, I think, deals with this phase of the diagnostic process. Many of us really think of the diagnostic process as that central analytic phase, that engagement of the patient and provider that consists of 4 different steps: the clinical history and interview, gathering the information, the physical exam, appropriate diagnostic testing, and then referral and consultation when necessary. And finally, the integration of all of that information to come up with a diagnosis. In review of these steps, the 2 biggest areas where errors can occur are in the diagnostic testing phase, in which a diagnostic test is not either available, it's not considered, or is not ordered, or the diagnostic testing may lead to an inappropriate result. And then finally, the integration of all that information to include a broad differential, the ability to account for all of the diagnostic possibilities. So these are the 3 phases of that conceptual model: the pre-analytic phase, the analytic phase, and post-analytic phase. And we have to think broadly in terms of diagnostic error because the impact and the solutions that we may have to reduce the impact of diagnostic error vary between these 3 phases. When we look at the sources of diagnostic error in internal medicine, what we find is that they are very complex and they're multifactorial. This was a study by Mark Graber back in 2005, and it's been confirmed with subsequent studies, looking at what was the underlying cause for diagnostic error. And what you see in blue here is that almost half of the errors are caused by both system and cognitive factors. An additional 28% are due to cognitive factors only, thinking processes. If we add those together, about 3/4 of diagnostic errors are related to a cognitive process, and that makes them particularly challenging. When we look at the different failure modes in diagnosis, they can really put into 3 buckets. There's what could be considered a no-fault error. These are ones where a patient presents acutely with a lack of symptoms or has very atypical symptoms that may be mimicking a more common condition. Unfortunately, this is kind of a baseline level of diagnostic error that we're never going to be able to reduce. They're just inherent in that process of practicing medicine. There are other system factors that are important in the diagnostic errors. That might be the lack of availability of resources, the lack of availability of prior records, testing, or expertise that's not available. And we can approach this source of system errors much in the way that we approach other types of system errors, We can take a very systematic approach. They can be reduced, but we have to constantly be monitoring them and checking them to make sure that they're not reoccurring. And finally, there's cognitive errors, that unique portion that contributes to diagnostic errors. These can be due to a variety of factors as well. Knowledge deficits. In radiology, the most common source of a diagnostic error is a perception error, which the radiologist doesn't identify the finding of the diagnostic target at the time of the initial report, but subsequently it becomes quite obvious. There are other types of cognitive errors where we have different types of cognitive biases that lock us into a limited approach to differential diagnosis that are important to consider. So these are unfortunately very challenging because they can be very contextual. They tend to occur in certain situations. They're very dynamic. They're very fluid. But we have to think about what are some systematic drivers that are causing these cognitive errors. So when we think about the different failure modes in diagnostic processes, it really starts to frame how we approach those different sources of errors. James Reason has the Swiss cheese model of how we might approach system errors, in which latent errors in a certain step of the process can be thought of holes within the Swiss cheese. But if we know where those errors are, if they're relatively fixed, we can design a process by which that system process is managed, in which those holes don't overlap. So we provide levels of redundancy to reduce the risk of patient harm occurring from a system error. Unfortunately, cognitive errors are a little more challenging. For one, we don't have many steps in the process. We only have one or two slices of Swiss cheese. And unfortunately, those latent errors can be quite contextual. If we're working in a very busy clinic, the risk of having a cognitive error increases substantially. There's other system factors that can drive when those errors occur. We're prone to certain types of cognitive biases, availability bias and anchoring biases that are going to change where those errors occur. One of the other important factors is that we tend to think differently about cognitive errors. We tend to think of them in the person mode. Unfortunately, this can oftentimes impact the culture at which we address diagnostic errors. They tend to be a failure of the physician. If we think about what makes a great physician, historically their ability to make a difficult diagnosis. So we think of that as the art of medicine. Oftentimes what we don't appreciate is the impact that system factors can have on these cognitive errors. And that's an area where I think we have a lot of opportunity for improvement. So one of the other sources of cognitive errors is our over-reliance on heuristics, those mental shortcuts that we all have to implement in order to be able to get through a busy workday. If we look at how training impacts the onset of these heuristics, we take a trainee and we put them into a condition where they have to make a diagnosis. They tend to have to use a large amount of cognitive resources. They have to think very clinically and stepwise to be able to get to a diagnosis. And unfortunately, because of a lack of experience, they tend to be wrong quite often. As they get more and more exposure to a certain condition, they begin to develop a pattern of ability to make pattern recognition, and they develop these mental shortcuts or heuristics that ultimately allow them to become much more efficient in their diagnostic thinking and also much more accurate. Now, one of the problems that we have is oftentimes those mental heuristics that we use and are critical for making a diagnosis go untested. An example would be we make an initial diagnosis on a patient that we may be seeing in the clinic. After a few months, they go somewhere else for care. They have additional testing that changes that diagnosis. Now, ideally, we should get feedback and say, hey, remember that patient that you saw 18 months ago? Well, it turned out this was the condition that they had. And that way we would be testing these heuristics. And if they were wrong, we would be getting negative reinforcement back on them. Unfortunately, most of the diagnostic process occurs in a very fragmented scenario, and we don't get that type of feedback. So we make that diagnosis, the patient goes elsewhere, there's a change in the diagnosis, and we never get that feedback. As a result, we get this positive reinforcement that these heuristics that we're reliant on to make the diagnosis are accurate. And we oftentimes become overconfident in our diagnostic abilities. So when we think about what would be a more effective decision-making process, what we would like to do would be to have trainees develop these heuristics, develop that ability to make expert thinking and be very accurate, but also to constantly be monitoring and reflecting their diagnostic process. Where are the heuristics failing? Do they have a process to learn from their mistakes? Are they getting feedback and attention on those areas where there's errors? Where there's areas where they're not have adequate resources in order to be able to make these types of diagnoses. So heuristics work well, but they require constant monitoring and reflecting. We need to be thinking about how we think in order to become better diagnosticians. The other thing that needs to be considered is the role of human factors engineering. Increasingly, our diagnostic environment is reliant on technology. Certainly in a field such as radiology, where I work, we've become incredibly dependent on the technology that we work with. But one thing we oftentimes don't appreciate is the impact that technology has on our thought process. We tend to be driven by the technology rather than using the technology as an effective tool. So these system factors can modulate the risk of cognitive errors. If we think about the increased demands on productivity, that reduced time that we have to actually think about the process, to engage and think more carefully about what am I missing in this case, is often something that goes unrewarded and not given adequate attention. So to reduce the risk of cognitive errors, we can't change the way we think. That's a biological process. It is pretty much baked into our neurocognitive systems. What we can do, though, is look at how those system factors modulate the way we develop those cognitive errors. One of the things that we're particularly interested in looking at is the role of cognitive fatigue on perception errors in radiology. As we increase our productivity, we put greater demands on those neurocognitive process, where do we start to run into an area where we're at risk for making those types of mistakes? So in the future, human factors engineering would give us the ability to define the environments that we're working in and identify where are situations where we're at increased risk. Where do we need to stop or slow down and be able to think more carefully about the diagnostic process? Now, improving the diagnostic process is dependent on multiple factors. And in 2018, there was a nice working tool that was developed by a collaboration between the Society for Improvement in Diagnosis, the Health Research and Education Trust, and the Hospital Improvement Innovation Network. This change package, I think, looks at 5 major drivers that can be used when you're thinking about how do I improve diagnosis in medicine. And those drivers are effective teamwork, a reliable diagnostic process, engaging patients and their family members, optimizing the cognitive performance, and developing robust learning systems within our health practice. So we'll focus first on effective teamwork. Oftentimes we think of diagnosis, again, as a patient-provider relationship, but increasingly diagnosis is a team sport. We have to think about the most important member of that team, which is the patient and their families. We're reliant on them for getting critical information about the history of a condition, for following up on test results, for keeping us engaged. They're the one person who's present at all of these steps of this highly fragmented diagnostic process. The NAM report pointed out the important role for diagnostic subspecialists, such as radiologists and pathologists, in the diagnostic process, and recommended that we increase the way that they're involved and used in developing diagnoses. Nurses and allied health professionals are important as a member of the diagnostic team, and we have to look at better ways of capturing their input when we think about how to make diagnoses. There's a huge amount of diagnostic information out there in the literature, much more than any of us can begin to obtain, and we need to use tools that go beyond simple Google searches to be able to get this information back into the hands of the diagnosticians at a point where it's timely and appropriate. We talked a little bit about how these diagnostic errors are often thought of in person modes, and it really goes against some of the things that we've been trying to develop with a culture of safety. The diagnostic errors occur in a system, and we have to recognize that those system components contribute to diagnostic errors. Rather than casting blame or assuming that it's an individual failure, we have to begin to think more systematically about it and address the culture of safety as it relates to diagnostic errors. There's a lot of things related to communication that are important. One of the big ones is closing the test results. So involvement of IT solutions and our IT teams to be able to come up with ways in which we improve the ability to get timely and accurate communications back to individual members of the team is going to be critical. The other thing is developing a reliable diagnostic process. And this is an area where we probably can do a better job leveraging our IT networks. One of the important things is surveillance tools. And I think a great example of this is a program that Kaiser has developed called their SureNet program. This is a software tool that sits in the background and is constantly monitoring the EMR for certain conditions that may indicate inappropriate or delayed diagnosis. An example would be identifying those patients that have elevated creatinine and ensuring that that gets worked up appropriately, either by a referral to a urologist or with additional testing. They have similar type surveillance modes within this tool. For example, identifying those patients with an elevated PSA and making sure that they're getting appropriate follow-up for early detection of prostate cancer. So these early warning systems are something that we can begin to implement more robustly within our EMR, particularly with the advent of artificial intelligence and machine learning. I think we're going to see a lot of advances in this field over the next 10 years. There are a lot of things that we can look for as far as clinical operations in the way that information flows. Part of this is really making sure that we close the loop on test results. This is a big area where we oftentimes find that a diagnosis is made, but unfortunately was not communicated in the way that it was acted upon. This is one of the focuses of Act 112. We have a lot of other processes in place occurring now on a national level that's really focused on making sure that those test results are acted upon or are seen by the appropriate eyes, and that we're not failing to communicate those appropriately. We can leverage our technology increasingly to make sure that there's access to specialists, particularly in remote areas that may not have local content experts or the appropriate resources to be able to provide accurate and timely diagnosis. So the advent of telemedicine with programs like telestroke, there's subspecialty resources such as one that was developed out in Johns Hopkins that is looking at patients that are presenting with dizziness and increased risk for posterior fossa stroke, that we're implementing telemedicine solutions. In radiology, we've more and more becoming increasingly reliant on the use of subspecialty expertise through teleradiology resources. One of the things that we found years ago is that it's important to make sure that we engage those patients within the reliable diagnostic process. For us, one of the big risk factors that we identified was the patient presenting to the emergency room for an acute finding, but was found to have an incidental finding that needed further additional imaging. An example is a patient presenting to the ER for a cough was found to have a fairly clean chest x-ray, but might have had an incidental pulmonary nodule that required follow-up to determine what the clinical significance was. So these incidental findings oftentimes were falling through the cracks. It was not something that was going to be managed within the emergency room. Oftentimes these patients were from outside our own network, so we didn't know who the primary care provider was. It was difficult to get that information back to the appropriate provider to make sure that it was acted upon. So one of the things that we developed was directly engaging the patient. We started off sending them direct letters to inform them that they had a finding that required additional follow-up, that we would be happy to communicate directly with their primary care physician. And also, if they didn't have a primary care physician, they were within our network, we worked with them to make sure that they had a primary care physician. What we found is that the letters themselves did not work particularly well. Only about 15% of the patients were responding directly to the letters. So we've now followed that up with a more robust process in which the radiologist identifies the incidental finding. It's placed then into an electronic database where we work through those processes to make sure we understand what the finding was, what the recommended follow-up would be, and then we keep track of how that is being acted upon. We have a patient within the patient safety office. We have a nurse that sends the letters to the patient, follows that up with a phone call to make sure that that loop is closed. Then we work with the patient to make sure they have appropriate providers. But having the patient is directly involved in that process is really a critical component of making sure that you have a reliable system. So that, I think, is a good transition process. I'm now going to turn the presentation over to Kathy, who's going to talk a little bit more about how we engage the patient within the diagnostic process. Kathy.
Thank you, Tim, and thank you. I just wanted to make sure we were good there. Thank you, Tim and Becky, and good afternoon to all joining us this afternoon. So, yes, this is an excellent transition, and the next key or third leverage point in the 5 strategies from the HRET document is engaging the patients and family members in their care. So more specifically, what are we doing to create the environment to truly allow that patient voice to be heard and to hold weight? It's not just that we're creating space or encouraging them to speak up, but does it matter? Like, so if we ask people what they think, does it matter? Do we take it into account? It had stuck with me recently from having a conversation with some patient representatives in a dialogue who shared their experience of speaking up, but not always feeling heard when it comes to their course of care. One woman said, "If you're going to ask me what I think, then please listen." I'm sure many of you listening at some point have been in the role of a patient or a caregiver. Did you feel engaged as a member of your care team? If so, what went well? What did they do that worked so well, that made you feel engaged? How was that? How are you invited in to be a key part of the healthcare team when it comes to the diagnostic process? When we communicate with patients, are we simply imparting information, or are we confirming that the patient comprehends and is able to follow the guidance given? Being attuned to their living situation, other factors that they may be contending with, having empathy, can all really make a difference. Essentially, what we're saying is it's not just engaging the patient, but really working with them and truly partnering with the patient and or families and caregivers. So what role does the patient play? I think there's really two key areas in relation to diagnosis and improving the diagnostic process that are real opportunities for improvement. We need the patient to provide an accurate and complete medical history and a history of a current issue. And we also need to have confirmation that they understand the diagnosis or understand the guidance and what they need to do. The patient's toolkit for diagnosis, for which if in the materials that you received in the slide above, there's a link included, is available, and it's also available on the Society to Improve Diagnosis in Medicine website. It is a great resource to have patients and to help support them in being more engaged in their care and how they can provide more accurate input and be a more, as I said, engaged and impactful member of the team, of their care team. I also want to share that we should be using stories more, and the use of stories to talk about not only our experiences with diagnosis as clinicians being on that side of it, but if you've been in the role of the patient. And I know at the end of this webinar, like we do it all, we'll be encouraging you to ask questions. I'm also going to encourage you, this is, no pressure on anybody, but if you have a brief vignette or a story that you want to share of something that you've been involved in, I think that there's no time like the present then to encourage us to tell those stories and how they impact, because when we really, get away from strictly case studies and hearing about how things impact people's lives, either as a clinician or as a patient, you realize that stories get to emotions, and that's why they're such powerful motivators, and they can really be a true tool for leaders and change agents, people working in performance improvement and patient safety, because they really help to motivate people to change behaviors and in many cases to adopt different safety behaviors when you can understand sort of the impact of different choices we make. So I just wanted to share that. As I said, I'd really welcome to hear any of your stories of being affected by diagnosis or diagnostic error. I want to tell you a little bit about a project, a collaborative project in Pennsylvania. Just until a few months ago, and for the previous 2.5 to 3 years prior at the Patient Safety Authority, we were co-leading a project with the Healthcare Improvement Foundation. This project was under the HAPIN, which stands for the Hospital and Health System Association of Pennsylvania Hospital Improvement and Innovation Network. And this was one of the projects funded by the CMS Partnership for Patients program. This was a demonstration project with a goal to create standardized process and measures to prevent diagnostic errors for patients receiving treatment in the ED and having imaging tests while there. For this collaborative project, we focused on the ED for a few reasons, because it is an inherently risky environment with many distractions and coordination challenges. Imaging is often critical to accurate and timely diagnosis, and radiologists may not always be engaged as full members of the diagnostic team. So it was really an opportunity. Often silos exist between different departments. That's not unusual. And so also in this case between the ED and the radiology department. And the processes between the departments involve individuals in many different roles and can often be located in different parts of the hospital. So there was opportunity to really explore what system weaknesses there could be. We further narrowed the scope to focus on incidental findings in imaging in patients being treated in the ED. And I just want to point out that we've talked about incidental findings with this project, and Tim spoke about it as relation to the Failsafe project. And I just wanted to, there are real opportunity and right for system improvement, but I didn't want you to take away from this conversation today that diagnostic error is only looking at incidental findings. It's a much broader topic and opportunities in many aspects, but incidental findings is one area of opportunity. So as I mentioned, this is a demonstration project, and part of the work was developing a set of measures to try and involve the collaborative hospitals and key stakeholders in developing those measures. We knew they may not be perfect, but if we wanted to move beyond just talking about the issue, to try some things and to move into action. And if we were moving into action, we knew we would be learning something. Our measures centered on communication with patients who had an incidental finding on imaging in the ED, who were being discharged, and that there was some follow-up recommended. The hospitals participating worked out a process at their facilities to identify cases fitting the criteria, and then they tracked 2 process measures. One being the number of patients who were verbally informed, and that was indicated by documentation of that conversation, and the number of patients who provided with complete printed materials about the follow-up and recommendations. In all communications, 3 key elements were communicated, that being the nature of the finding, the recommendation for follow-up, and why it was important or why you would be concerned if they did not follow up about. So sort of stressing the importance of that follow-up. The third and outcome measure for this set was, can the patient, or is the patient able to verbalize and demonstrate a full understanding of the 3 key elements of their finding? That was really the crux of all of this. It was not that just the information was being imparted, but are we taking that extra step to verifying that the patient is capable, understands, and at least able to follow up with those recommendations. We did not require or dictate methods used, but we provided resources for vetted methods, such as the teach-back method for demonstrating, or for the patient demonstrating understanding. And as I said, it wasn't perfect, but we were learning, and the participating hospitals were sharing with us what they discovered as opportunities in their systems that came to light by looking at this narrow subset, and the changes they made had ripple effects. So some concrete takeaways of what we learned fell into really 4 buckets. There was identification of a need for standardization. Hospitals worked with their radiologists and their radiology groups to really create some standardization around the language used. So not everybody was using incidental findings in the reports. The language about things that needed follow-up weren't always in the same place. Sometimes they got kind of buried in the report and were hard not only for the discharging clinicians to see, and then that information not passed on. So standardizing the templates of reports and where the recommendations for follow-up would be made things much more efficient and concrete for everybody involved, not only the patients, but the clinicians. Difficulty with measurement, as Tim had mentioned on a previous part of his talk, that it's difficult to measure diagnostic error, and they did express the struggles that they had with that. A lot of it was manual, identifying the cases, and then somebody having to, read through to make sure that nothing was missed. And a part of that drove the standardization of some of the reporting. But teams worked with their IT departments and developed reports to help make all of it as efficient as possible. And some of those reports became very useful, not only for this project, but just in general of being able to capture different opportunities for patients, things that might fall through the cracks in follow-up. So those things, as I said, had some ripple effects. Improved communications. Hospitals took great strides in improving their interdepartmental communication, as well as communication with patients and with their primary care physicians. They worked to reduce turnaround time so that they could have those final results and, as much as possible, have face-to-face conversations with those patients in the ED before they were discharged, and an opportunity for some teaching. We also heard, stories where departments between the ED and the radiology department had just developed some direct expectation of direct one-to-one conversation, so in real time, so they were able to follow up on things. When the radiology department, I think it was the director of radiology, would identify that there was a patient or there was a finding, would make sure that the director in the ED knew about it, and that patient, would have that conversation, or the conversation would be had, so that there wasn't slip through the cracks. And they reported to us that even though that was driven by this project, their communication overall about everything was just better between the departments. There's also, regarding the importance of accountability, that our hospitals reported that identifying physician champions was really key, and not only in the ED, but also in the radiology department. And they discussed various processes that they had implemented to achieve that ultimate goal of communication with patients. So all in all, we're talking about engaging the patients. We, especially throughout the project, use this visual of a road and going down the road quite a bit, because when we started out, I know I've said this before, as a demonstration project, and we used to say it was very much a learning journey. We didn't know what would happen. We didn't know how these measures would work out. And we looked at it as like a long road with turns ahead that we weren't able to see very clearly, far down the road. But as we moved, if we acted and moved further down the road, things would straighten out a bit, and things would get more clear, and we would just continue to develop as we went. So as we developed through this project, we realized even though we were focusing on patient communication, we weren't working directly with the patients. We weren't engaging them directly in their voice. At least the project team was not. The hospitals were. So later in the project, we had the opportunity to have a focus group with some patient representatives from the HAP Patient Family Advisory Council, and that proved to be very eye-opening. So we learned a lot from those patients. They told us that, I shared about the idea of being encouraged to speak up, but then not really feeling heard or not feel like that mattered. So there's, a call to be genuine if you're going to really ask people to speak up, that you're taking that into account. I want to stress here for anybody that is, moving into working on diagnostic error, improving the diagnostic process at their facility. So we want to engage patients not only as patients or in their clinical care, but also in the work that we're doing to improve. A lot of recommendations today are that we're partnering with patients in the improvement work as well. So if you're thinking of starting a task force or developing a committee around diagnostic error, improving diagnosis, what about a patient representative on that team? Literally having them at the table as a team member during your improvement process. So it's truly being on the road together and involving them not only when they're in the role of the patient, but also as a member of the journey of improvement at your facility. Another key leverage point is to optimize cognitive performance. In many ways that can be done, such as clinical decision support, clinical reasoning education, and reflective practice. Clinical decision support is a broad term that includes tools such as best practice alerts in the EMR, order sets for specific conditions, and differential diagnosis generators. So what happens when we have a lot of well-meaning tools firing at people trying to take care of patients? Of course, we run the risk of alarm fatigue. So just keep that in mind. We also want to be thoughtful and judicious with what tools we employ. And the fifth and last key leverage point is what is always important in patient safety is how are we continuously learning from diagnostic error events? How are we, continuously learning, becoming learning organizations? And I would also like to stress here that learning is important when things go wrong, but just as valuable when things go right. What's working well? Many of you may be familiar with root cause analysis as a thorough tool to identify latent failures in the system. Another example here is a method called Diagnostic Error Evaluation and Research Taxonomy, or also called the DEAR taxonomy, for analyzing diagnostic error events, and that link to that tool is included in the slide above. Without time to go through details, I will point you to the resource slide in this deck, including a link to an article where we at the authority utilize the DEAR taxonomy to do an analysis of events entered into the state PACERS, or Patient Safety Reporting System. This tool helps to identify failures in the diagnostic process. While we use this tool in our state-level aggregate data, the tool can be used by an organization to do the same with some of your events. This is where we want to move the conversation on the topics to where we think of diagnostic error in terms of thinking, well, where are the breakdowns in the system? Where are there opportunities to improve diagnosis and have that proactive approach? And with that, I will turn the conversation back to Becky.
Okay. Thanks, Kathy, and thanks, Dr. Mosher. This was an excellent presentation. And as we wrap up the slide portion of the webinar, I would like to take a minute to reiterate to everyone listening that diagnostic errors are the most common, catastrophic, and costly of all medical errors. As you listened to this presentation, I'm sure you thought about at least one thing you can do to improve safety in the diagnostic process in your facility. So I encourage everyone listening to identify something you can start working on today, no matter how small. As the saying goes, if we wait until we're ready, we'll be waiting for the rest of our lives. The time is now. And finally, at the beginning of the webinar, I mentioned the project currently underway in our Center of Excellence and wanted to give you more information about that. We're running a bit short on time, so I'm going to keep it short so we can get to all of your questions. The project we're working on is focused on creating a comprehensive assessment tool for Pennsylvania hospitals to identify facility-specific gaps and that will help to set priorities and strengthen the key structures that are needed to improve the diagnostic process. This may sound familiar to some of you because as part of our environmental scan for this project, we've been visiting with teams in Pennsylvania hospitals over the past few months to better understand current perceptions, structures, and processes related to diagnostic error and improving diagnostic quality and safety. As we move forward with this work, we will keep you updated on our progress, and we'll be sure to let you know when the finalized tools are available for you. In the meantime, here is a list of resources that will get you started. These are all hyperlinked in the PDF document with the slides. Again, if you need the slides, you can access them by hovering at the bottom of your screen, clicking on the chat bubble, and then clicking the link that will take you to the slides. Now let's begin our question and answer period. Okay, first question. What is something we could do at my facility to engage nurses in this issue and have them see themselves as part of the diagnostic process?
This is Kathy, and I'm going to speak up, and Beck, I'll encourage you too, because we're both nurses. What comes to mind initially, which I think applies across most challenges, is start the conversation. And I know that sounds very like that's a non-answer. No, I very much mean that there's one simple thing that everybody listening today could take away is let's ask them. If we're asking, what could we do? What could nurses do? Let's go to nurses and ask them. I think it would take not much to, grab an informal group together to have a conversation or bring this up on the agenda of your next, I'm going to say shared governance or staff meeting or whatever kind of venues you already have scheduled in your organization where you have nurses, frontline nurses and leaders. And it's even ideal if it's a mixed group, if you have any kind of a committees together where there are residents or there are doctors and nurses together or other parts of the team and other departments as we talked about, part of the team of diagnosis. And we've given you a lot of resources here. The Center of Excellence is available to you that we could help having this conversation or facilitating that conversation. But it's, sharing what the challenge is and then saying, where do you see yourselves? Where do you think nurses fit against this, the diagnostic process? Where do we see, what we do in our workflow most impactful along these phases? And, sort of moving that into what ideas do you have? What do you think we could do? What could we look at? But to answer the question, I think the most, what's something that we could do at our organization is creating space or an invitation to start that dialogue. And as I said, we're here to help you with some background information, or whether that be just to provide some resources like some of what we have here, or to have some consultation, or even to come to your facility and sit at the table and be the facilitator for the conversation. It would be your conversation, like your team talking, but we could be there to, get the conversation going and be that facilitator. That would be very interesting to me. So that would be my suggestion. I don't know if you have anything to add, Becky.
Oh, I think you summed it up really well, Kathy. Thank you for answering that. Looks like we have a question that is specific to, I'm assuming, the Failsafe project, Dr. Mosher. It says, calling patients in addition to sending the letter seems like a big lift. How many staff perform that task, and how did you get that started?
First, it is a big lift. We have two nurses that are working in that area, one that the primary has primary responsibility over it. The reason that we felt we had to go to that level was that when we actually followed up on the impact of the letters, we found that we weren't accomplishing what we thought we were accomplishing or what we were hoping to accomplish in engaging the patient. So we really had to have somebody actively managing that work list. And I think other organizations that have implemented a program such as Failsafe, and I'd say there are quite a few that are out there, recognize the need to have direct engagement of the patient. You can't just assume that sending out a notification is communication. The communication has to be a two-way street. There has to be a feedback loop on it. And we found that the phone call was the easiest way to do that. I think once we've had the nurse navigator managing that, and it is managed through our patient safety office, we have a much higher level of follow-up on the recommendations. And I think it takes away some of that inherent risk of assuming that patients just getting notification are going to act on that. Oftentimes they either don't recognize the significance of it, it gets lost. They get a lot of letters from the hospital, and they oftentimes don't appreciate the significance of that one letter. So I think it's really important to make sure that those resources are allocated to it. If you're going to be committed to following up on the safety results, I think you have to do it well.
Mm-hmm. And a follow-up question in line with your response, how tenacious are you? How many calls and how hard do you try?
Pretty tenacious. So I'd say everybody gets a letter and a phone call. Based on those phone calls, and I think oftentimes you have to make multiple phone calls to get through, you need to have a tracking process by saying, did I call this patient? What was the outcome of it? What is the next step? A lot of the more robust systems that are now, and there are some IT workflows now that are being used to track this, follow all the way through to make sure, did that patient get the appropriate follow-up study? Was it ordered? Was it performed? What was the outcome of that result? Is that case now closed? And so I think that's quickly becoming the standard of care when you look at institutions that are implementing this type of system. It's one where you're not done until that loop is closed.
Okay, thank you. We have about 4 minutes left, it looks like, so we can probably take 1 to 2 more questions. The next one we have here is, how are we incorporating this into teaching programs for new clinicians? And is there a best method or approach to teaching them to adopt a different mindset to improve diagnostic accuracy, given that there are system and cognitive factors?
Well, this is Tim. I think there's a couple areas where we're really focusing it on the education curriculum. One is around team-based care. So as part of the team-based care, the elements of communication, looking at how teams think differently from individual providers and how we can leverage that in a way that improves diagnosis is important. I'll give you a good example. There's a program that's been implemented in a hospital down in Australia where they have on rounds a red team and a blue team. The red team makes the initial diagnosis, and then the blue team has 3 minutes basically to shoot holes in it. Basically it's a forcing function. What am I missing? What are we not thinking about in there? So there are ways in the training programs where you can get people thinking about those types of inherent biases that we're all prone to, and what types of systems such as this can we use metacognitive processes to begin thinking about where those errors are occurring. I think the other big area is just awareness. We've started a program here at Penn State. It's an elective, 2-week elective program where our medical students are digging into that NAM report and looking at, okay, there's 8 general recommendations that the National Academy has put forth in order to reduce the harm from diagnostic errors. But how do I take those high-level things and begin to develop opportunities to put those into real practices? And they've come up with a wide variety of different ideas in better ways of engaging the patient, better use of the patient portal, looking at system factors and environmental factors that increase the risk for cognitive errors, such as, phone calls in the reading room or interruptions in the clinic that take away from that cognitive thinking time. And then actually trying to approach this from kind of robust areas. So I think from an education standpoint, it's really beginning to think about diagnostic errors much in the way that we've thought about other types of system errors. and begin to take a systematic approach to it. I think it's probably the two things that we're really focusing on.
Okay, thank you. I don't see any additional questions. Shelley, if I'm missing any, please let me know. Okay, so it looks like we've made some really good timing here. It's 1:59. So as we wrap up, I'd like to again thank Dr. Mosher and Kathy for the great information you provided during the webinar today. I want to thank everyone for joining us today. If you experienced any issues accessing the evaluation or certificate of continuing education, please feel free to direct any inquiries to Shelley Meixel at shmixell@pa.gov or contact PSA support staff at 717-346-0469. This concludes our webinar. Thanks again, everyone.